anesthetic management.
Mm.
So coming to the indications for aortic cross clamping, it is usually done in open repair of the descending thoracic or abdominal aortic aneurysms, or to temporarily reduce a blood loss in case of trauma, where we can either do a surgical cross clamping of the aorta, or we can do an endovascular technique with resuscitative endovascular balloon occlusion of the aorta. It is also cross clamping of aorta is also done to isolate the heart to administer cardioplegia. Coming to the pathophysiology of aortic cross clamping, whenever the aorta is cross clamped, there are two changes that occur. One is proximal to the clamp and one is distal to the clamp. Proximal to the clamp, there is always hypertension, and distal to the clamp, there is hypotension. Thereby, there is reduced perfusion to every single organ that follows after the whatever branches arise after the aorta is clamped. The amount of ischemia depends on two factors. One is the duration of the clamp application. Second is the location of where the aorta is cross clamped. Now, coming to the areas that are in proximal to the clamp, because of increased perfusion and increased pressure, there is increase in the afterload of the heart, and in case because of, and there are also acute vasoconstrictors which and catecholamines which are released because of the cross clamping. This increases the arterial resistance, and there is also passive venous recall distal to the clamp. This increased arterial resistance increases the afterload of the heart. In case the patient has an already impaired left ventricle, this also increases the risk of myocardial infarction and left heart failure. In patients with normal myocardial function, this causes increased coronary blood flow. Now, coming to what happens distal to the clamp. Distal to the clamp, there is reduced perfusion, which increases the risk of ischemia to the organs. There is also passive venous recoil. Thereby the venous capacity reduces. Here we can divide it into two subclassifications. One is the supraceliac clamp and another is the infraceliac clamp. For the supraceliac clamp, when there is a reduced venous capacity proximal to the clamp, there is shift of the blood volume into the venous capacitance system. So there is increased blood volume and blood flow to the proximal areas proximal to the clamp. In the lung, there is increased lung blood volume, which can cause pulmonary edema. It can also cause increased intracranial cerebral blood volume, and it can cause increased preload. In infraceliac clamping, there is shift of the blood into the splanchnic vasculature, and depending on the sympathetic tone of the vasculature, it can either increase the preload if the splanchnic vascular tone is increased, or it can decrease the preload if the splanchnic vascular tone is increased. The proximal hypertension that is caused by the clamping can increase the BP by up to 7 to 10%, and this can increase the cardiac filling pressures. This is usually treated intraoperatively by the use of vasodilators, for example, nitroglycerin. We can also increase the depth of anesthesia, but the problem of giving vasodilators is that there is a risk of reducing the perfusion pressure and can further exacerbate the ischemia of organs. Next, coming to the humoral effects of cross clamping. There are a couple of reactions that happen because of the release of vasoactive substances. One is acidosis. This acidosis is primarily due to increased lactate, which is caused by anaerobic metabolism because of ischemia in the areas distal to the clamp. The duration of clamping is directly proportional to the amount of acidosis that occur. Next is due to clamping, there is especially in suprarenal clamping, because of reduced perfusion, there is activation of the renin angiotensin aldosterone axis, and this further causes increase in catecholamines, which cause further ischemia to the organs. There are lots of inflammatory mediators that are released. One important inflammatory mediator is tumor necrosis alpha. This this is known to cause lung injury especially after reperfusion. Next, coming to the these are the effects of clamping of the aorta. Next, coming to that of unclamping. When the aorta is unclamped, there is reduced vascular resistance and there is a drastic fall in blood pressure. This fall in blood pressure and increased vascular permeability will cause a fluid shift out of the intravascular compartment. This can also cause increased washout of the mediators, and it can further reduce cause central hypovolemia, and it can reduce venous resistance. At the end, it can cause a reduction in cardiac output. So we have to be prepared for clamp removal. A couple of ways in which we can prevent hypotension, drastic hypotension is, one is to reduce the pulmonary vascular resistance by preventing hypercarbia, preventing hypoxia, and reducing the pain stimulus. One is we can reduce the depth of anesthesia. Secondly, we can start inotropes to maintain the myocardial contraction. We can carefully load the patient with fluids, and to prevent rapid fluid shifts due to unclamping, we can do a slow removal of the clamp, or we can do a partial removal, or in case the partial removal causes a lot of hypotension which the patient is not able to tolerate, this can be followed by reclamping. To prevent ischemic reperfusion injury and release of reactive oxygen species, we need not hyperoxygenate the blood, but we can maintain normal oxygen tension. There are a couple of techniques that are described to control hemodynamic responses for the cross clamping. One is we achieve a clamp time of less than or equal to 30 minutes, which is called the single cross clamp technique, whereby the surgeon finishes the repair within 30 minutes of cross clamping. Another is the use of a God shunt. This is a heparin coated shunt, where it is a passive shunt, and they've given an example where shunt can be placed from one is from the proximal connected to the distal part of the clamp, and the blood flow through the shunt depends on proximal pressures. But one disadvantage of the God shunt is that it requires partial anticoagulation. Another disadvantage is that there is a risk of atheroembolization if we apply a God shunt. Next is we can put the patient on a partial left heart bypass, whereby the left atrium can be cannulated, and from that it can enter into a cardiopulmonary bypass circuit, and then it can return back into a distal branch of the aorta. One advantage is that this doesn't require as much coagulation as what is needed for a complete bypass, and with the use of heparin coated shunt, this can also, the anticoagulation can be reduced. Here, the proximal mean arterial pressure is maintained to around 80 to 90 millimeters of mercury with a flow rate of 1.5 to 2.5 liters per minute, so that we can achieve a distal mean arterial pressure of 60 to 70 millimeters of mercury. To further prevent end organ ischemia, the surgeons can do something called a sequential advancement of the cross clamp with reconstruction. But one disadvantage with the partial left heart bypass is that the need for heparinization causes a risk of bleeding. Another technique is, in case the aneurysm involves the proximal aortic arch where clamping cannot be possible, we can go in for a complete cardiopulmonary bypass with a deep hypothermic circulatory arrest. This protects the spinal cord and other mesenteric organs from ischemia. One precaution that we need to take is that we have to monitor the patient for a potential left ventricular dysfunction during hypothermia, so that a prior TEE should be done. And in case there is LV dysfunction, we have to ask the surgeons to introduce a drainage cannula in the left ventricle. The disadvantage of a cardiopulmonary bypass with the deep hypothermic circulatory arrest is that it requires complete heparinization, and there is also a limited safe period for the deep hypothermic circulatory arrest, and there is risk for stroke from retrograde aortic perfusion, and there is risk of bleeding. There are two complications of aortic cross clamping which are very dreaded. One is paraplegia and another is renal dysfunction. First, coming to paraplegia. Paraplegia occurs in almost 6 to 10% of people who undergo aortic cross clamping. This is due to reduced spinal cord perfusion pressure. Usually this occurs if there is ischemia at the mid-thoracic level. To understand the reduction in the spinal cord perfusion pressure, we need to know something about the anatomy of the blood vessel of the spinal cord. Each vertebral artery gives rise to one anterior spinal artery and a pair of posterior spinal arteries. The single anterior spinal artery supplies the anterior 2/3 of the spinal cord where the motor tracts usually arise from, and the pair of posterior spinal arteries supply the posterior 1/3 of the spinal cord where the descending tracts pass through. Now, this anterior spinal artery is usually fed by a lot of radicular arteries. In thoracolumbar spinal cord, there is an important artery that supplies that feeds the anterior spinal artery, which is called as the arteria magna or the artery of Adamkowicz. Now, in case of if there is prolonged cross clamping time, or in case there is reduction in this particular perfusion pressure of this artery, there is ischemia that can occur to the anterior spinal artery, which can cause reduction in the spinal cord perfusion pressure and can cause motor paralysis. This ischemia has a classical presentation of motor paralysis with the preservation of proprioception because that is carried by the posterior spinal cord. Usually, this type of paraplegia is immediate onset paraplegia, and reports have seen that they usually do not recover that well. Some ways to prevent this paraplegia is to reduce the aortic cross clamping time, is to induce hypothermia to reduce the metabolic requirements, and to increase the spinal cord perfusion pressure either by reimplantation of the arteries or by lumbar drainage of the CSF so that there is a pressure of less than or equal to 10 millimeters of mercury. We can also augment the aortic pressures by use of vasopressors to maintain mean arterial pressure of 85 millimeters of mercury or above. Of late, a lot of people are preferring intraoperative neuromonitoring in terms of somatosensory evoked potentials and motor evoked potentials. Post-op serial neurological examinations can also be done to find out paraplegia earlier. Pharmacological interventions include steroids, barbiturates, or other CNS depressants, magnesium sulfate, mannitol, intrathecal papaverine, and naloxone. Next, coming to renal dysfunction. Renal dysfunction is again, the risk is increased when there is prolonged ischemia time. It is also seen due to rhabdomyolysis from the cardiopulmonary bypass circuit. It is more often seen in type 2 and type 3 thoracoabdominal aneurysm repair. To prevent renal dysfunction, we have to give adequate perioperative hydration. Intraoperative mannitol or furosemide or dopamine or phenyldopamine is also tried. Intraoperative cold renal perfusion with blood or crystalloid is supposed to be helpful, and maintenance of the lower extremity perfusion pressure will also prevent postoperative renal dysfunction. That's it, sir.
So, to elaborate an answer, the question actually asks is what are the pathophysiological or physiological effects of aortic clamping and cross clamping. I'm afraid whether we'll be able to have time to complete this answer in your theory paper. So you can prune it a little bit more to avoid all the techniques of how you want to prevent the complications like going on to even cardiopulmonary bypass that level. Okay. So I'll just show you this.